We will see the pathophysiology of hypertensive crisis. The transition from mild hypertension or normotension to hypertensive crisis usually is precipitated by an event that leads to an abrupt increase in blood pressure. Situations associated with this event may include cessation of hypertensive medications with the potential rebound effects, consumption of illicit drugs, and severe pain, as well as several clinical syndromes. Blood pressure is determined by the product of cardiac output and systemic vascular resistance. In most hypertensive crises, the initial rise in blood pressure is secondary to increased systemic vascular resistance. The rise in systemic vascular resistance is believed to be caused by humoral vasoconstrictors. With the increase in blood pressure, mechanical stress on the arterial wall leads to endothelial damage and fibrinoid necrosis of the arterioles. Vascular damage leads to loss of autoregulatory mechanisms, ischemia, and acute end organ damage, which prompt further release of vasoconstrictors, thereby initiating a vicious cycle. The precise pathophysiology of the hypertensive crisis remains unclear. However, two different but interrelated mechanisms may play a central role in the pathophysiology of the hypertensive crisis. The first is the failure in autoregulatory mechanism in the vascular bed. The autoregulation system is a key factor in the pathophysiology of hypertension and hypertensive crisis. Autoregulation is defined as the ability of the organs to maintain a stable blood flow irrespective of alterations of perfusion pressure. If the perfusion pressure drops, the corresponding blood flow decreases temporarily, but it returns to normal values after the next few minutes. In case of autoregulation malfunction, if the perfusion pressure drops, this leads to decrease in blood flow and an increase in vascular resistance. In hypertensive crisis, there is a lack of autoregulation in vascular bed and blood flow, and so an abrupt increase of blood pressure and systemic vascular resistance can occur, which often leads to mechanical stress and endothelial injury. The second mechanism is the activation of renin-angiotensin system, leading to further vasoconstriction and thus generating a vicious cycle of continuous injury and subsequently ischemia. Besides these mechanisms, a prothrombotic state may play a key role in hypertensive crisis. A recent study showed that sp-selectin, that is soluble p-selectin, was significantly higher in patients with hypertensive crisis compared with normotensive controls regardless of the presence of retinopathy, which suggests that platelet activation is a relatively early findings in the pathophysiologic sequelae of hypertensive crisis. Pathophysiology of hypertensive emergency. Initial event is an abrupt rise in BP from an unknown stimulus followed by compensatory mechanisms from the vascular endothelium. This endothelium releases nitric oxide, that is a vasodilator. Arterioles sense the rise in BP and arterial smooth muscle contracts to reduce the rise in BP. Vicious cycle with prolonged arterial smooth muscle contraction leads to endothelial dysfunction and the inability to release more nitric oxide, resulting in further increase in BP. Shearing forces on the vascular wall result in further endothelial damage and dysfunction. Endothelial dysfunction results in the release of inflammatory markers, that is cytokines, endothelium-1, endothelial adhesion molecules. It promotes platelet aggregation, coagulation, and endothelial permeability, vasoconstriction and thrombosis, hypoperfusion, and end-organ ischemia. Patients with chronic hypertension have adapted to the higher BP. Patients who are normotensive and have an abrupt increase in BP do not have any adaptive mechanisms. Even a small abrupt rise in BP can induce a hypertensive emergency.